All right, so we're gonna get started here. Sorry for the delay. We just cut a cake and gave Dr. Hagab a surprise gift from all the fellows. So where everyone's just eating now. I'm just telling people on Zoom. Sorry. I'm not like reiterating to everyone. Sorry. Yeah, no, not talking to myself. Okay, so I'm Vashti Sharma. I'm one of the Neuropulmonary Critical Care Fellows, and I will be presenting on cystic fibrosis for the general pulmonologist. So today's agenda, what we'll go over is an overview of the disease, its pathogenesis, how to make the diagnosis, the evolving therapies that have grown over the past 30 years, how to manage an acute exacerbation, and what the role of transplant is in these patients. So first of all, cystic fibrosis. So it's a specific hereditary form of bronchiectasis. It's actually the most common genetic disease in the white population. It's approximately 1 in every 3,000 births, this mutation is detected. It's autosomal recessive with variable penetrance, which can play a role in how the phenotype varies so much in some of the patients that do have cystic fibrosis. And the gene itself is located on chromosome 7 on the long arm. And that gene was isolated fairly recently, 1989. Where do we see it? So this is a global present, I guess, depiction from the Journal of Cystic Fibrosis that looked at the density, the prevalence, of cystic fibrosis in the world. It's mostly seen in North America. We have a lot of cystic fibrosis in North America, especially the United States, and also Europe. It's fairly common. What I also came across was in this journal, they looked at all the registries across the world, actually all the countries in the world that have a registry, and they looked at various demographics of patients with cystic fibrosis. So I thought we would look at Canada and the United States, you know, us being in North America, and what do we see here? I think something interesting that I came across during my reading was that the reason why people with cystic fibrosis are living so much longer now is because we have the role of not just the therapies that have been developed, but the development of care teams that are very multidisciplinary. So everybody with cystic fibrosis will most likely be seen at a center. And the big things about this is that within this team, there's a care coordinator, there's a nurse, there is a respiratory therapist, there's a physician, there's a dietitian, and all of these play a huge role in these patients' disease process, especially nutrition. And what I think is interesting when we compare Canada to the United States with cystic fibrosis is they're roughly diagnosed around the same age, at least the newborn screening. They both have newborn screening, and the median age of diagnosis in Canada would be 6 months versus 4 months. But the median age of predicted survival is actually quite different between the two countries. So 51.8 years versus 41.6 years, which actually is like almost 10 years between the two countries that are neighbors that all have a universal screening program with the development of these CF centers that have all this multidisciplinary approach. And I think what people are thinking the biggest reason for that is the access to care. So access to care in these patients is extremely vital to getting the treatment they need because they need very close follow-up. So in the United States, a lot of people are falling through the cracks and not enrolled in the CF centers as they should be, sort of. So looking at the CFTR gene overall, so this is a picture of it on the right. Like I said, it was discovered in 1989, and what does it do? Well, its job is to pump chloride out. And so what happens here in the normal cell, you're having chloride pumped out of the cell by your CFTR gene. Sodium binds up this chloride, and then you have less sodium influxing back into the cell. And as we know, where sodium goes, water goes. So in cystic fibrosis, when you have a defective CFTR, you're not getting that chloride pumped out, and the liquid volume on the surface is a lot more dense because sodium is influxing in through your ENaC channels, water is following that, and the mucus that is left behind is less watery, more viscous. this mutation itself, so this is kind of an intense slide, and a lot of the details we don't really need to know as general pulmonologists, but I think it's important to realize the pathway and where things could go wrong, because this is where the treatments we have play a role. So the distribution of these mutations was divided basically into 6 functional classes. So class 1, we have a defect in the protein synthesis, and that's usually from stop codons that get transcripted early on, or there's deletions or mutations, so the gene itself doesn't get translated. Class 2 mutations are mutations where we have impaired protein trafficking. So you have this gene that's translated, but it can't get from where it was translated up to the plasma membrane where it acts. Class 3 mutants, these are defective channeling gating. So it reaches the cell surface, but it doesn't exhibit the channel gating properties it should, and either because of ATP, it has defects in its ATP binding, or for whatever reason it gets to the surface, doesn't work. Our class 4 mutants, these mutants, they get to the plasma membrane, but they have some sort of decrease in the conductance of chloride. So there's something within the protein that doesn't work. Our class 5 is, actually doesn't really, honestly doesn't matter too much for us. Basically, they get to the membrane, but doesn't work. I'm realizing as I'm saying this, kind of irrelevant here. The only reason is that because we know the pathway of all of these different mutations that could occur, we have areas to target when we start talking about treatment. So that's why this is helpful. Okay, so how do we diagnose cystic fibrosis? Well, generally, you have our signs and symptoms and clinical presentations, which we'll talk about, but the big things that we'll know, especially based on the prevalence of the disease in which area you're living in, is a family history and if they had a positive newborn screen. So a lot of countries have newborn screening. And what does this look for? So it looks at increased levels of immunotrypsinogen. And immunotrypsinogen is actually a pancreatic enzyme, and it is released when the pancreas itself is damaged. What's kind of surprising is that there is already enough pancreatic damage in these patients in utero that it can be detected while they were still, while the mother is still pregnant. So it's actually interesting that it eats away at the pancreas so early on. So once you have a positive newborn, or you have family history, then you would go ahead and do a sweat chloride test. Based on the number found on your sweat chloride test, that will put you into different categories. So the CFTR gene, the CFTR transporter gene, when you have this receptor in the skin versus in the lung, the easy way to think about it is that it does the opposite. So in the skin, and the external skin, you're actually having more chloride outside, therefore more salt. And that was actually the earliest forms of detection of cystic fibrosis in the 1940s, was people with very salty sweat. That was kind of the first time it was ever realized or documented. So after that, depending on what your sweat chloride testing is, you would then undergo genetic analysis. And by that point, they're probably at a CF center that they've been referred to look at all of these mutation examples that were in our previous slide. So what is the pathogenesis of this disease? So it's important for us as pulmonologists because this dehydrated mucus is what causes the majority of morbidity or mortality in these patients. This decreased viscosity essentially leads to impaired mucociliary clearance. At that point, you're going to have more persistent bacterial infection. You'll have increase in cellular debris that lives within that dehydrated mucus, and you'll have progressive dysfunction leading to bronchiectasis, eventually worsening obstructive disease, eventually pulmonary hypertension, and death. Majority of these patients do succumb to the illness because of respiratory issues. So why I liked this picture here is because it kind of talks about the CFTR gene receptor and what happens when you have the surface water active surface liquid depletion. So they don't have a lot of surface fluid, therefore it becomes more thick. You have a defective clearance, it gets obstructed, you get infection, inflammation, and it's just a cycle that keeps going. These small gray boxes are ways that we can intervene upon to kind of help the symptoms of what's happening in this. So since we know that most patients succumb to their disease due to respiratory reasons, I thought this was an interesting graph to look at this point in time. So most of us here were probably born between 87 and 91, most of us trainees here. And so imagine that would be sort of not, no, I was just trying to show that like this is our age basically. Like so imagine back I know I'm getting deeper and deeper, but I'm just trying to say, so imagine at our age, I don't even say it. So dying, I should say dying early. You see that, like 28 to 30, like back then, living past 30, it was very rare. And that's basically like our age. Imagine succumbing to your illness so young. And just in the matter of 33 years, look at the significant change in life expectancy that cystic fibrosis patients have had. And a lot of this is because of the research and funding from the Cystic Fibrosis Foundations, and everything we'll talk about on this next slide. So why has this life expectancy so significantly improved over the years? Well, looking back at the very beginning history of the disease, like I sort of mentioned earlier, in the 1940s, I guess late 1930s, that was the first pathologic description written down about cystic fibrosis. Later on in the early 50s, that's when people were having those presentations of very salty sweat. That's kind of how people were presenting. The first chloride sweat test wasn't developed until 1960. So we didn't really know why they were so sweaty or salty, but sorry, now there's a sweat chloride test in 1960. Fast forward a couple more decades, and the protein that I initially talked about was first found in 1989, which was huge. So a lot of these patients, we didn't, before we even knew there was this protein, there were various other therapies being given before we even identified what the CFTR protein was. Come even later was the CF gene that was identified on chromosome 7 of the long arm. So over time, we have significantly changed what we know about the disease. And as you can see, the age goes from 25 to 30. And after identification of the protein, we've had significant changes in mortality of these patients. So how do we approach treatment? We'll start off first with the Cftr modulators, because this is fairly new. Actually, a lot of them have come out just in the last couple of years. And the Cftr, it's a cyclic AMP anion channel. And I kind of mentioned this before, it transports chloride across the epithelial surface. And if we know how this protein is translated, folded and made, and then transported up to the plasma membrane, maybe there's some way we can interfere in that pathway. And here's sort of a depiction of that pathway. So they've broken down the Cftr modulators into a few classes of therapies. So these few classes, knowing, how the protein works, there's 5 possible targets we could act on. So the big broad categories would be potentiators, correctors, stabilizers, read-through agents, and amplifiers. So even though we have these 5 possible targets we could help with the CF protein along the way, there's only 4 current therapies that have reached the market. So yes. So the first one, the correctors. So these are small molecules. They essentially enhance the stability of the CFTR. And the 2 medicines that they have for this are tezacaftor and lumacaftor. And the second one, the potentiators, those are for the class 3-4 mutations that we sort of talked about initially. That's ivacaftor and elexacaftor. And then stabilizers, they've been doing studies on trying to find ion channel stabilizers that anchor it at the plasma membrane, but nothing has really yet come through the pipeline to pass phase 3 trials and be on the market as of yet. Now, I was going to say here, so how did these medicines sort of come up? So there's 3 trials that have been instrumental in proving that these therapies are effective. So the first one I'll talk about is the EVOLVE trial. So this trial studied the effects of tezacaftor and ivacaftor in cystic fibrosis patients, and they were at least 12 years old when they were enrolled in this study. How this trial went is they were randomly assigned to get either tezacaftor daily by itself or in combination with ivacaftor. And they compared these two groups, so those with tezacaftor, ivacaftor, with a placebo. And what they had found was that the group that had the combo pill, the tezacaftor, ivacaftor, they had an improvement of 4% from their baseline FEV1, and the FEV more than 4% compared to the placebo, sorry. And they also shown that those that were on the dual medicine compared to placebo had a 35% decrease in their admissions to the hospital just from the combo pill. And generally in a lot of the CF studies that I was looking at, they generally present their results with these 4 findings. It would be the BMI, it would be sweat chloride concentration, actually it would be FEV1, which is not in this one, and the respiratory domain score. And BMI is a huge predictor of mortality in this disease, and that's also because of the malabsorption and the pancreatic insufficiency that these patients have. So you can see here with changes in BMI, there was improvements in BMI in those with the dual therapy. There was a decrease in the amount of sweat chloride with the dual therapy. And I didn't put it in this, but they were decreased exacerbations and improvements in the FEV1. So overall, it was actually really good study. So the next thing they wanted to look at was something called the EXPAND trial. I'm sorry, this is the one where they said, okay, we know that the dual therapy with the tezacaftor, ivacaftor has improved FEV1, has decreased your risk for hospitalization, improved BMI, as well as the sweat chloride levels. But what if we just did monotherapy with ivacaftor? Would there be the similar benefit or not? And so in this EXPAND study, patients were randomly assigned to either get the dual therapy, the monotherapy, or a placebo for 8 weeks. Afterwards, they had an 8-week washout period, and then they actually switched to the other 2 treatments. And they kept monitoring these patients over time to see what the result was. And what they found is both the dual therapy and the monotherapy both had significant improvements in the FEV1 when compared to the baseline. So there was a 6.8% improvement in FEV1 on patients with dual therapy and a 4.7% increase in FEV1 with monotherapy. So both of these showed improvements in their FEV1 after this treatment. So after knowing that dual therapy is better than monotherapy, then is there a role for triple therapy? So this came another study. And so this was a phase 3 double-blinded randomized active controlled trial that was also enrolling patients 12 and older. And what they did in this case, so they did a 4-week run with either ivacaftor, so single therapy, or dual therapy. And then after that, they were randomly assigned to have either the triple therapy or an active control. And the active control could have been mono or dual therapy. And the primary endpoints they looked at in this study were the FEV1 again. And what they found was fairly promising. So this was the initial period where these are the 2 active controls that they did. So it's ivacaftor or tezacaftor, ivacaftor for the active controls, and that was your placebo. And this was the triple therapy versus our active control with changes in FEV1. So there were significant improvements in FEV1 with triple therapy. And there was also a significant drop in their sweat chloride with triple therapy versus the active controls of being mono or dual therapy, which is interesting. Actually hadn't seen a study designed like this before, so it was a bit tough to wrap my head around initially. And then this was kind of the big advertising ticket that came out of the study that's in a lot of the ATS magazines and such when it first came out. And they really wanted people to see that all these patients that underwent this study with triple therapy had improvements in their baseline FEV1. They even had improvements in their sweat chloride. So there is definitely a role for this triple therapy versus dual or mono. So overall with the CFTR modulator drugs, who we give it to is sort of based upon age. And so there's guidelines for patients above the age of 6 and below the age of 6. And all of these whether you're a candidate or not has to do with what specific mutation that you have. And I think for the purpose of this lecture, it's sort of beyond our scope, but there's depending on all the dozens of mutations that were in that first slide, they would or would not be candidate for this therapy. So what is something else we can do for treatment for these patients? Another one, so ion transport inducers is something they're also looking into, but not yet, really. Just those 4 that I just talked about were currently being, we have medicine for. So airway clearance is our next topic. What are some airway clearance techniques? So airway clearance techniques for cystic fibrosis patients should be standard as a daily therapy for everyone that has productive cough. The viscous airway mucus caused by cystic fibrosis needs to be alleviated somehow, and they found a various number of methods to help with this. What's interesting is that there are no superior methods. So all of these have been found equally effective. Some examples that I have here is the flutter. This is like the flutter valve. It's sort of like an a cappella device. This is the vest that actually plugs in. So this is preferred by most people just because you wear it and then it provides chest PT just while you're wearing it. Here we have active cycle breathing. So this was a video of her teaching active cycle breathing. So it's just deep breathing and just breathing techniques to help bring up mucus. And then here we have intrapulmonary, we don't have that here, but there's also intrapulmonary percussive ventilation. And so this is another device that's, I think it's mostly in the hospital. I didn't see any of these at home because that's to hook up into something else, and it creates vibrational forces. It's kind of like a flutter. It's kind of like a chest PT vest, but more direct into the airway. And so I don't know. Yeah. That's the same thing. Acapella, right? Yeah. That is what it. I think I have that here too. No, it's okay. I was going to say something else about these devices. Oh, right. I will get into it actually, because the nebulized therapies for them is different than like every other nebulizer that we generally use for other patients, but we'll get into that. What was interesting is all of these techniques are also equivalent to just exercise. So 30 minutes of aerobic exercise was similar efficacy to these therapies. And why is this particularly important? So I liked this graph because it showed the mucus that builds up in the airways between 2 very common obstructive diseases we see in pulmonary, asthma, COPD. And what you can see here is you have mucin, you have plasma proteins, you've got a lot of inflammatory cells. And where asthma and cystic fibrosis sort of are different, when COPD and cystic fibrosis are different from asthma, is that there's a lot more cellular debris in that mucus. So there's more DNA, there's more actin, there's more bacteria. And look at how much more there is in cystic fibrosis. So getting this mucus out as part of the airway clearance techniques is very important for these patients. The longer that mucus stays there, the more you are at risk for not colonization, actually, that's the wrong word for cystic fibrosis, for infection and worsening inflammatory cascade and leading to more tissue damage, bronchiectasis, and worsening lung function. So we have those airway clearance techniques, but what about airway clearance drugs? So these are the airway clearance drugs. This image on the left was taken from the Cystic Fibrosis Foundation pipeline. They actually on their website have all of the drugs that are currently being studied and sort of where they are in the phase. Not everything would fit here, but currently the ones that they have that are available to patients is Pulmozyme, hypertonic saline, and inhaled mannitol. So Pulmozyme degrades DNA that will accumulate within that mucus, and you will see a change in FEV1 with use of Pulmozyme, and they were also found to have fewer exacerbations in patients that were taking Pulmozyme. No matter what stage of cystic fibrosis you are at, it is always recommended to be used. Second thing is hypertonic saline. So the thought behind hypertonic saline is that, so this rationale is that if you're putting more salt into these secretions, you will therefore bring more water into these secretions, make it more liquidy and be easier to cough it up. Now, the strength of saline used is high. I think it's like 7% or even higher. It's something that we don't actually carry usually. So it's a bit hard to get here in the hospital, but cystic fibrosis pharmacies carry it, and that's something that people can use. The only issue with that is a very common trouble is coughing and wheezing, especially if these patients have underlying asthma or any other reactive airway disease that it's not tolerated very well. And now mannitol is only really recommended as a second-line therapy if you have failed usage of Pulmozyme and hypertonic saline. Now, what about the role for bronchodilators? So the thought is if we're going to use bronchodilators, you use it prior to your nebulized antibiotics, which we'll talk about. But there hasn't been many clear studies that showed a very strong improvement just based on bronchodilators alone. So what was also found is gradually in childhood, patients do respond to bronchodilator therapy, but as they grow older, there's so much lung destruction already that they become less responsive to bronchodilators. Of course, we would not use LAMAs because this will increase the secretions and worsen their mucus burden. So this is kind of just a summary of what I just said. So the inhaled DNAs and the hypertonic saline, you would use it short acting before the treatment if you were going to use it. And DNAs or hypertonic is for everybody essentially. Now, antimicrobials. So that's another treatment approach that we can be targeting for these patients. And why is that important? Well, this is, I think, is a good table that or chart that is going to look at all the different organisms that are found in cystic fibrosis patients. So this was taken from the Cystic Fibrosis Foundation registry. And as you can see, when you first start to see Pseudomonas for the first time, this is when you absolutely need to eradicate it. And why that is because chronic Pseudomonas infections, the Pseudomonas itself can then become the mucoid phenotype. And when you develop the mucoid phenotype, it has, it's very destructive to the lung tissue. It increases, it drops your, those with mucoid phenotype have a very sharp decline in their FEV1, have a very rapid decline in their general health and have a lot of exacerbations. So the rule of thumb is when you find Pseudomonas in cystic fibrosis patients, you have to treat it. And then you have to follow up in 30 days to make sure it is eradicated. Those that had the I did say that this is the same difference in the FEV1s between the mucoid phenotypes and those without. And this is sort of the role of nebulized antibiotics. This is what brings up this role of the nebulized tobramycin or aztreonam. So the studies that looked at tobramycin and aztreonam actually showed similar results, but getting aztreonam available is just somehow less available. So most people use inhaled tobra. And something to note, when you nebulize these antibiotics, it's a special type of nebulizer. It's not the same type that you would use for COPD patients. So what are the 4 approaches to our antimicrobial therapy in cystic fibrosis? So we know what bugs grow. So how should we approach them in terms of antibiotics? So one would be chronic prophylaxis to prevent specific infections. So that would be the inhaled tobramycin. The current recommendation is that you have inhaled tobramycin and you do it on an on-cycle, off-cycle basis. So you do it for 28 days straight, then you don't do it for 28 days. And then you do it for 28 days straight and you don't do it. And that's always, you always want to prevent getting Pseudomonas. Second is whenever you do detect a new pathogen in sputum cultures, because these patients are followed very regularly. So every 3 months they'll have a sputum culture. So as soon as you detect Pseudomonas or detect a new pathogen, you want to very quickly and aggressively eradicate this bug and check to see that it is cleared. The third approach would be the chronic suppression, which we just talked about. And then fourth is have a system in place to palliate signs of pneumonia as soon as they come up, because when these patients get sick, they will likely almost always need to be admitted for IV antibiotics, and we'll get into management of the admitted cystic fibrosis patient in just a second. So, yeah. If they grow in the culture, but the patient's not. Yeah, you would still, and it used to be based on an FEV1, and then based on it's like class A, B, C, D of cystic fibrosis lung disease. But now they're saying that you should just do it. Everyone should be on cycle, off cycle, on cycle, off cycle, because their mucus burden is so high that they will eventually basically get Pseudomonas. There was something about Cepacia as well that it's also seen, but the biggest things are Pseudomonas. There isn't a lot of MRSA that is being seen. That is something to say as well, despite the very close contact with healthcare providers and being in the hospital, and they don't really see a lot of MRSA in these sputum cultures. Interesting. So how do we prevent infection? So vaccines. So all patients will have your annual influenza, and nowadays when everybody wears masks anyways to coming to the clinic, it's not a big difference, but prior to COVID, all cystic fibrosis patients would be in an isolated room. It would just be them and their care team. Everybody would wear masks to prevent any type of spread of infection. So that's sort of how the preventative roles are. There was some suggestion for palivizumab early on, but the foundation is no longer recommending any type of prophylaxis with that. So to prevent acute exacerbation. So this is for all patients with persistent. So there was, but you also do it, so sorry, when people that have not grown it yet, but depending on their FEV1, you would still do it. And so 28 days on, 28 days off. What else is this? I think we talked about the rest of the stuff on the slide. All right, so the last sort of leg of therapy are anti-inflammatories and whether they are helpful or not helpful in treatment. So this was from the Cystic Fibrosis Foundation. This is also part of their in the pipeline, actually available to patients, got cut off here on the right, but this was some of the things that they are studying right now to see if they have any inflammatory effect, but nothing has really come to be available to patients yet, except for high dose ibuprofen. And high dose ibuprofen is mostly used in kids. Actually, it's only used in kids. So it's indicated for children aged 6 to 17. And what they found is that in adults, the amount of ibuprofen they would need to reach serum levels to be effective would be so high that they just weren't really seeing any benefit of that. So we don't use ibuprofen in adults, but in children they do. Second thing would be azithromycin. So oral azithromycin is recommended is recommended 3 times weekly as an anti-inflammatory. And the only caveat to not giving it is patients that have a previous infection with non-tuberculosis mycobacterium. And that is here. Yeah, so the high dose ibuprofen isn't really used in the States, but in other countries with CF, this is sort of what they are doing. And the role of ICS, inhaled glucocorticoids, in these patients is really just if you have asthma or any type of underlying asthmatic symptoms. So what do we follow these patients for in the outpatient setting? So big targets are BMI and FEV1. So FEV1 is followed with spirometry every 3 months. These patients are checked, and with sputum cultures every 3 months to see if they ever develop a new infection. They need to be treated right away and checked for eradication within 30 days post-treatment. Other big targets is the BMI. So there is a very high correlation with lower BMI and death in these patients. So we always want BMI in women to be over 22 and in men over 23. It's a very poor prognostic sign for cystic fibrosis patients. And that sort of ties in with exacerbation and acute management. And so when these patients are admitted to the hospital, initially, when they first do come to the hospital and they're being treated, in terms of nutrition, most of our diabetic patients, we would put on the diabetic diet and give them the insulin they need. With cystic fibrosis patients, you want to give them an aggressive amount of caloric intake. So you want them to have a lot of calories, multiple snacks, and the pancreatic enzymes they use are different compared to what's generally given to patients for chronic pancreatitis. So they require much more pancreatic enzymes for their absorption of them. So things to keep in mind for food and so forth. Other things for what do we do with the inhaled tobramycin? So if this is a patient that's on cycle, off cycle, and now they're getting admitted for IV antibiotics from an infection, you would still continue their inhaled tobramycin depending on the cycle they're on. So if they're on cycle, you just keep giving it, even if you're giving them nebulized as well as IV, and vice versa. If they're off cycle, you keep them off cycle. So you basically just keep them in their routine. And what will define an exacerbation in this patient population? So you would need at least 2 of the following things I'm about to say. So a change in sputum. So it's sort of like some similarities to COPD exacerbation. So change in sputum or volume, an increased cough, changes in their fatigue levels. If they're having any anorexia or weight loss is specific to cystic fibrosis. If they're having a decrease in their pulmonary function. So any FEV1 that changes more than 10%, or any new radiographic changes, if they have any of those with the symptoms, you'd want to admit them for an exacerbation. And so these patients, when they're admitted, they get systemic antibiotics. We're going to intensify what they're doing for their clearance. So if at home they're doing twice a day flutter vest, you would do chest PT like Q4, and just kind of increase the therapy they're getting. Systemic glucocorticoids like oral prednisone or methylprednisone only play a role if they have an underlying, if they have asthma or they have something else. But if it's just for, if they only have cystic fibrosis, there is actually no role for systemic steroids. And the last question here is actually the last slide, is what is the role of transplant in these patients? So the graph on the right, well, I'll just say first. So this table on the left was compiled from the International Society of Heart and Lung Transplant. And these are the guidelines that essentially are put forth by many of the CF institutions. And this is who we should be referring if we're seeing them outside of a CF center, which I don't think really we would be, but just in case, patients that are over the age of 18, if you have FEV1s that are less than 50, or they're rapidly declining, or if it's less than 40 and they have poor disease progression, so more than 2 exacerbations, having massive hemoptysis, or nutritional status. So if their BMI is less than 18, it also needs to be referred to a transplant center. And patients that are under 18, so in peds, those are the, I guess I don't have to read out loud, but and any of the other patients at the bottom, is interesting because there's a lot of criteria there that probably many people with chronic obstructive disease meet. So a lot of these people should be seen by a transplant center fairly early on. So 6-minute walk test, less than 400 meters, hypoxemia at rest, hypercarbia more than 50, and pulmonary artery pressure is greater than 50, because as their bronchiectasis progresses, they will develop worsening pulmonary hypertension. And these people should be seen sooner rather than later from a pulmonary, from a transplant center. In terms of the transplants that have been done, so from January 2000 to 2017, there were almost 1,000 lung transplants done in children. And there was almost 7,000 transplants done for adults. So they are transplanted, I mean, a lot. That was from the registry. There's the international registry. That's from all the CF centers that I kind of highlighted in the very first slides of where a CF is and how many those are the areas that have centers with databases that a lot of this data comes from. And what's interesting is what's their survival. So these are some common reasons for transplant. You've got COPD, ILD, cystic fibrosis, alpha-1 antitrypsin, and the survival and mean survival post cystic fibrosis is actually almost 10 years, which is higher than all the other kind of transplanted diseases that we see. So there's definitely a role for transplanting these patients if they continue to progress. And I think as we're seeing that they're living so much longer now, it's not uncommon at all for patients to be in their 60s. We know that the data from Canada showed average age of 51.8, and in the States 41, but in general, people are living longer. So this may be something that we will start seeing more and more of as we're seeing more people survive to the point where they need a transplant. Yes. Any questions for me?
So once they get transplanted, how quickly does the bronchiectasis, like, because I mean it's a mutation, right? So
I don't think it would be in the transplanted lung though. Yeah, like the bronchi and everything that are in the transplanted lung are already there.
So like,
right?
No recurrence at all.
Yeah, typically it's not recur. I mean, people get chronic rejection frequently, like similar type, they get similar type disease, but
talking about. You're gonna give this like regardless. This is like with like how we would use like an ICS lava or
Mhm. Yeah, so the chronic maintenance, what did I say here? So the oral azithro for that, that would be for patients that have had Pseudomonas infection in the past. So the 3 times a week azithromycin is for the people that have had Pseudomonas ever before. Those are the ones that go on that anti-inflammatory. And the cycle 28 days on, 28 days off. So I have to check it because my slide says something strange there, but I thought that it was, if you ever had Pseudomonas ever, you're always going to be on that 20 days on, 20 days off. But then there is also indications based on what your FEV1 is that you would just be on it 20 days on, 20 days off. But I have to confirm that. I don't know if anybody knows that. Yeah. But yeah, so they're on a lot of chronic therapy to help prevent help prevent infection. Yeah, don't use the word colonization.
One of the questions that I have is about CFR medications, right?
Mhm.
You mentioned, you know, that at best triple therapy is about 6% improvement in FEV1. How clinically significant is that? Especially when we, you know, just at baseline look at changes in percentage of FEV1. Wouldn't consider that a significant thing.
I think that I only mostly presented the FEV1 data because of this lecture, but I think that in general improves their nutritional status as well. So their BMI is improved. They can actually hold on to weight more. And when they're holding on to more weight, they're more active, they're more participatory, and because the adherence because it's very aggressive, all the things they have to do all the time. And when they're healthier and they're participating more in the chest PT every 4 hours, going every 3 months to give your sputum. And I think when those markers improved, they had better adherence to their long-term therapy. And that's why they're seeing such significant increases in life expectancy. They're living longer because I think as a whole, not just affecting the lung, but the whole body is that Cftr modulation is throughout the body and all the organs that it is. I think that's more the effect we're seeing for them living longer.
Yeah, so I think that's a really important point, right? So even though the numeric difference in the FEV1, you know, for all intents and purposes, we normally would think of as clinically significant, all of the other markers in terms of their overall health improves with that therapy. I think it's always important when we look at the literature to think about it in that standpoint. What is sort of numerically important, but more importantly, what impacts the overall health outcome.
Anything else? Oh, yeah. What was the question? Yeah, that wasn't, I didn't come across that at all, actually, which is strange. In all of the things I read, I didn't really see that. No, I don't know why. Same, yeah. Because I think that's originally what it was studied in, was cystic fibrosis patients, but in all the like recent guidelines I've seen it, I haven't really seen that come up. Maybe they just found it was inferior to the other methods. Let's see here. Yeah, I don't know. Anything else? All right, thank you guys.